Welcome back to the podcast, and we are going to have the second in the series of stat cases today with the lovely Dr. Matt Young and Dr. Laura Tickle and me, Angela Nate.
Hello!
Hello.
So Matt.
Yes.
Tell me about your case.
So I've got, it's an interesting case. It's a chap I saw, well, it's before Christmas actually, so almost 6 months ago now. I was covering resus on one of our days, and I was handed a blood gas we have a rapid assessment area where the patients come in and they have blood ECG done, and they get seen by normally one of the consultants. And I got handed this blood gas, and I was told this patient's going to resus, and he had a slight metabolic acidosis, and he had a very raised potassium. His potassium was over 7. I can't remember it again precisely, but it was definitely over 7, between 7 and 8. So quite raised. And he was going into resus because he used to have calcium gluconate and instant dextrose and everything like that for the standard hyperkalemia management. And most of the time when you see patients like that, they often, hyperkalemia is due to lots of different causes, but the most common being acute kidney injury. So they're often a little bit sort of septic or a little bit dry, or often elderly, on medications, etc. All those risk factors that come to our minds when we're thinking about acute kidney injury. He didn't really have any of those. So he was a little bit old, but he was only 70, he wasn't, in his 80s or 90s. He wasn't on any medication. He was normally fit and well. And he had a slightly odd story of 3 days of this vague sort of tummy pain. It was sort of central epigastric type pain. It was all very odd. It didn't sound like anything in particular. Didn't do much. Was sort of a bit intermittent and then a bit constant and then a bit of this and that. And again, it's a very odd presentation. He was vomiting, but not a lot of vomiting. He was vomiting sort of 3 or 4 times a day, not sort of excessive. He wasn't in too much pain either. He was relatively comfortable. And the only other thing to note on his blood gas, his lactate was a little bit raised, it's about 3, and his calcium was slightly raised. It was a little bit odd, a little bit strange. So from the history, I had sort of vague differential of, actually, is he in bowel obstruction? And one of the concerns from taking a slightly more detailed history, after I didn't understand what was going on, when you go back and you speak to the patient again, he'd lost a bit of weight over the past couple of months, and he looked quite cachectic and quite frail. And I sort of, had that always sort of think, is there an underlying malignancy or something when you see patients like that? And so I came up with a differential of bowel obstructions. I wonder if actually he's got a bowel tumour and he's obstructed, and that's why he's vomiting. And he had opened his bowels the day before, and so it wasn't clinically obstructed. He did have bowel sounds, I remember. And I fumbled about and I got him an erect chest X-ray, which was normal. And I didn't really know what was going on. So I gave him fluids, a bit of antibiotics, pain relief, etc. And spoke to the surgeon. So I don't really know what's going on because you can't see him. They kindly obliged. And then the next thing I know, we got a phone call from the biochemistry lab saying he's got abnormal results kind of everywhere, really. Would you mind looking at them? And he has an amylase, which is over 5,000, which is very raised. He had a calcium of 3.5, and he had a massive AKI, so he had a creatinine about 800. And it was significant for several reasons. Firstly, we catheterised him as part of our sort of sepsis 6 treatment, and there wasn't a lot of urine coming out of his catheter. And again, in his past medical history, he was noted on a CT several years ago to only have 1 kidney, which he didn't know about at the time. So he's only got 1 functioning kidney normally, which based on his blood tests is not functioning, based on his urine output is not functioning. Massively raised calcium, massively raised amylase. And so especially the intensive care guys, and he eventually went up there for a bit of hemofiltration and just sort of definitive care, basically. And he's one of those patients that sort of followed up, and he turned out to have an underlying lung cancer that had caused him to become hypercalcemic, which had caused him to have pancreatitis, which had caused him to put himself to bed, which had caused an AKI, which had caused hyperkalemia. I thought it was a really interesting sequence of events. It's something I often ramble on about to the students, is there's often only one pathology really going on in most patients. It's very rare to get 2 distinct pathologies. There's often only one thing driving the whole process. And with that guy, I just couldn't work out what was going on. And so I was sort of treating him symptomatically. So he was slightly sort of borderline pyrexia, tachycardic, slightly hypotensive. So we were treating him for sepsis, presumed intra-abdominal sepsis. But actually he had pancreatitis. And he needed lots of fluids to treat his hypercalcemia, to prevent that sort of further pancreatitis. He obviously needed treatment for his hyperkalemia. I thought it was just interesting, that sequence of events, and it just brought it home to me. It's something that you need to be aware of, that we need to treat the underlying cause of most of our patients.
Don't take the first presentation at face value.
Yeah.
Dig a bit deeper.
So, did he have a history of breathlessness, or was it just particularly weight loss?
I didn't ask him.
Why not?
Because ED, I don't do
Seemed
thorough
irrelevant
histories.
at the time.
Yeah, exactly. He had some clear stuff I could treat him. I could send him somewhere. A clear disposition, which was he needs to come into hospital and be treated by somebody else. I didn't go full detail. From memory now, I don't remember asking those things at all.
You didn't know until he got to ITU that he had the lung cancer?
Oh yeah, no, I didn't.
Yeah, so it wasn't a question.
So he had a normal looking chest X-ray, and then somebody cleverer than me. I know it's rare. Somebody cleverer than me. He ended up having a CT thorax abdo-pelvis like the next day, or maybe the same day, looking for a cause of pancreatitis, but also to rule out malignancy based on how he presented. And that showed that picked up the lung cancer. But no, I didn't ask him. It didn't seem relevant at the time, and I think that's one of the learning points, is that it's having a nice broad net, and I didn't consider. I thought he might have had a malignancy, but I sort of, in many ways, I anchored on the fact that because he's got abdominal symptoms, he's got pain, he's got vomiting. This must be a bowel tumour. And ultimately, from my perspective, it doesn't matter where the tumour is. The matter is that he's got a tumour that is causing these symptoms. But actually, asking about shortness of breath and night sweats and all that sort of stuff might have been helpful for his ongoing care.
That was a point that we touched on in simulation this morning, though, is sort of accepting, when you are the first person seeing a patient and reviewing them, accepting that you aren't necessarily going to get to the bottom of this trail of events. Yeah. And particularly when you're doing an A to B, you are treating reactively as you go along. So it's a really interesting case, but for the students, when you're doing an A to B, you're not expected to get to the bottom of that within one assessment.
Yeah.
So it's an unusual presentation of pancreatitis.
Yes.
With an amylase that high,
yes.
You would have expected him to be more symptomatic.
I would expect him to say, it hurts at the top of my tummy and radiates through to my back.
Yeah.
And he didn't.
And the pain would be more extreme than he was presenting with.
Yeah. He was uncomfortable, but he wasn't, if I'd seen him without any blood results, I wasn't particularly excited by him. There's nothing really about the history of this pain or the vomiting or his abdominal findings that alerted me to actual clinical concern. I suppose that's why we do blood tests. Examination has a sensitivity and a specificity as all blood tests do, as all investigations do, and that's why we investigate further.
It also, back to the pancreatitis, it wasn't one of those top two causes that we think about in pancreatitis, which is gallstones and alcohol use. It was quite an unusual cause.
And scorpion bites, obviously.
And scorpion bites.
Being a medical student classic.
Yes. It was quite an unusual cause, pancreatitis.
Yeah. It's one of those, it's not, hypercalcemia is one that's not at the forefront. I think that the third is idiopathic, but we never find out anyway.
Yeah. And ERCP.
So again, it's that absence of a clear clinical diagnosis that prompts you to investigate further.
So looking back on it, is there anything you think you would have done differently?
Probably not, to be honest. As with all sort of resus patients, did an A2E, treating as you're going along. His A2E was pretty standard, to be fair. He wasn't particularly unwell, certainly from a physiological point of view. He had a slight circulatory issue in that he was mildly hypertensive, a bit tachycardic, but had some fluid and antibiotics, which stabilised that aspect. We treated his hyperkalemia, partly with anything else, so calcium gluconate, insulin dextrose. Although interesting, actually, the insulin dextrose, we didn't start based on the VBG. I often don't, although there's lots of good data coming out. I can put a link to the show notes of certain studies which show that the sodium, potassium and creatinine on a blood gas are the same or equivalent to the lab scenarios. Yeah. But in practice, we often don't treat with insulin dextrose until we have the lab confirmed gas, because there are potential complications, hypos and all that sort of stuff with the insulin dextrose treatment. Antiemetics, pain relief, we've got an erect chest X-ray, and it is after that initial A2E, you come away and you've got that information and you've got the snippets of history. And you sort of go like, what's going on? What are my top differentials? And it's sort of like, I didn't really know. As I said at the time, I thought maybe some sort of weird obstruction or some underlying thing. I think as Ange probably pointed out, I probably could have explored the potential malignancy thing a little bit more, because I noticed the weight loss, but that was really, I didn't really ask about other constitutional symptoms and night sweats and things like that. Having the blood test, once we got that did change our thinking drastically, and we really appreciated that he needed a lot more fluid than we thought he did, because we gave fluid to stabilise his blood pressure, so he didn't have a lot, 500 ml to a litre or so, as part of my initial sort of A2E treatment. And then actually, once we saw the hypercalcemia, he needed a lot more fluid. We gave him 2 or 3 litres in the end, and he had, obviously the poor urine output went on the filter for a little bit. So it sort of come back to the question, would I do anything differently? Probably not, but I might take that sort of second history, when you go back after initially stabilising, and I'd probably make that a bit more thorough.
So I imagine that working in ED, it's different, whereas the fact that you're dealing with the acute presentation and not there to diagnose the patient and be involved in their long-term management.
Yeah, that's probably fair. We're blunt instruments, as you're saying. No, you're right. We're there to deal with the problem. We do sort of diagnose what's going on, but we're not there a lot of the time for definitive care. We are not definitive care for the majority of patients that we see, and our job is to stabilise, work out what's going on, and refer appropriately. Whether that's discharging and referring appropriately, whether that's admitting and referring appropriately.
Okay, so to summarise, thank you, Matt. That was a really,
you're welcome.
That was a really interesting case, which demonstrates the complexity of the chain of events in a lot of pathophysiologies, and how your initial A to E won't necessarily unfurl that completely, and how it's important when taking history to keep an open mind about what the diagnosis may end up being.
I think for me, one of the key sort of take-home messages is not to anchor too heavily on anything, because I sort of, once I've done my initial A to E, sort of focused a bit too much on this chap probably has an underlying bowel cancer and that's caused an obstruction, and actually obviously the diagnosis turned out to be pancreatitis and all that sort of stuff. And I think that's probably my key learning point from that is don't anchor too heavily.
Yeah.
Keep a broad in mind, as you say.
Avoid tunnel vision.
Avoid tunnel vision. Thanks very much for listening. As ever, if you've got any interesting cases or anything you want to discuss with us or for us to discuss, then get in contact with myself or Joe, or do a tweet at us.
Twitter at us. So remember, next time you see a case of pancreatitis, don't forget to get smashed.